Welcome to Healthcare Algorhythm. I'm Dr. Will Strimel. If you want the real story behind today's healthcare challenges and the strategies and technologies people are actually using to solve them, you're in the right place. Short conversations, clear insights, practical takeaways. Let's get into it.
And hello again. Welcome back, everybody. This is Dr. Will Strimel on the Healthcare Algorhythm. It's a pleasure to have you today. And it seems already that the COVID pandemic is starting to feel like a distant memory. But one of the biggest changes to healthcare delivery actually came out of that experience, and that was the broader use of telemedicine. But in many respects, it seems as though we've kind of hit a wall with sustaining the use of it, which is really unfortunate because it was a great way to improve access to healthcare for many of us, including certain populations like seniors and those who live in rural communities. Well, today I'd like to welcome Dr. Rada Sumareva. She's the CEO of ZiphyCare. And in my view, ZiphyCare is working on what may be the missing piece in effective telemedicine adoption, and that is the ability to perform a meaningful remote physical exam. Rada, I've been looking forward to this conversation and learning more about what you're building. So thank you so much for joining me.
Thank you for having me, Will. And I'm very much looking forward to discussing this with you as well.
Great. Now, I think many people are familiar with the concept of remote patient monitoring, whether that be through home health or even things many of us use right now like Fitbits and our Apple Watch and an Oura Ring. But explain for everyone what you're talking about when you say remote physical exam and how ZiphyCare is building it.
Sure. So everybody talks about telemedicine these days, and it indeed improved access to care to so many patients, especially those that live in rural areas, those that homebound or live in underserved communities. However, telemedicine in the standard way that everybody thinks about it has some limitations. When we talk about older people, people with disabilities, people that live in underserved communities, sometimes they don't have high bandwidth internet, they don't have computers, they don't know how to operate technology. On the doctor side, on the care delivery side, there is also so much that you can diagnose without figuratively putting your hand on a patient, getting some objective data from the patient. So ZiphyCare is actually bringing the best of both worlds, in-person and telehealth. How we do it? In our model, there's somebody like somebody who is cost efficient, a medical assistant, a licensed practical nurse, a EMT that comes to patient location, whether it's a pop-up clinic or patient's home, with our proprietary technology. Think of it as a primary care cardiology pulmonology office in a suitcase. That suitcase also has built-in Wi-Fi connectivity, so you don't have to rely on patients' internet connectivity. When they arrive to patient's location, they open the suitcase, connect via video conferencing with the doctor, and become an extension of their arm. That person applies stethoscope to patient's chest. The doctor on the other end of the internet is auscultating heart, lungs, examines the throat, examines the ear, examines skin, wound, EKG that's done in real time. Everything that the doctor otherwise would do in the physical facility, except the doctor is remote. There is somebody who is by the patient's side who is navigating this equipment. Actually, all of the files, all of the sounds, images recorded on the platform. So you can compare the sounds and images 2 weeks ago to now.
Wow.
You can share them with other care team members, specialists, primary care doctors, hospital physicians, care managers from the insurance company, anybody from the care team who is allowed to have access to patients' data now has access to this raw data from the exam, which enables true continuity of care, which sometimes we are lacking when there are multiple really brilliant specialists caring for the patient and patient has hard time navigating the system and connecting the dots.
So not only that, this is interesting. I wasn't even thinking about this aspect of it. Not only are you able to deliver that capability remotely, but it sounds as though you can even in some ways objectify the physical exam because, I'll tell you as a cardiologist, I can listen to a murmur, a heart murmur, right? And I may call it one thing, another one may call it, and of course we have electronic stethoscopes, but it sounds like you have embedded in this ways to actually take that raw data, and I guess a lot of it's acoustic or visual, and really objectify it to not just kind of observe it in the moment, but track it over time. Is that correct?
Absolutely correct.
Wow.
That's exactly how we enhance in-person house calls. There are a lot of companies that are sending providers, nurse practitioners, doctors into the patient home. However, most of the time they arrive with a stethoscope, if any equipment. None of it is digital. So you only relying on diagnostic capability of that individual. And also nothing actually stays available for the system for the care
Right.
team members. In our case, we collect all of this broad diapason of data from that visit. By the way, the
So,
platform itself is very robust. It connects three schedules between the medical assistant, patient, physician. It also collects all of the data that we get from the intake forms, from all of the assessments done on the platform, from all of the tools in a toolkit. We have 8 patents. Some of them are on utility and design, and some of them are actually on the use of this comprehensive data for predictive analytics to predict the likelihood of the patient getting readmitted, the cadence of visits to the patient, the content of the visits to patients. Just to make sure that doctors' time is used efficiently, we replicated the workflows that doctors use in their physical and brick-and-mortar facilities.
mhm.
They have up to 4 virtual exam rooms, and they can come in and out of those virtual rooms as
You
prompted
mean
by.
by meaning that people could be in 4 different locations?
Yes. Yes,
Wow.
yes,
Now, you're the founder of this, correct? If I
yes.
read that correctly, and you've been doing this I think almost 10 years or right around 10 years. So,
A little less. It took us some time to build the technology.
correct. That's what I mean. Like, so you had where did the vision come from? What inspired you to make because even at that point, it would have seemed this is going to be really challenging technology to build. So what made you, what gave you a passion around it? What made you believe you could do it?
In addition to being part of multidisciplinary delivery teams for a couple of decades, I
Hmm.
was also involved in so-called organized healthcare. I was a part of United Healthcare quality committee where we would work on programs that would improve utilization rate of preventative services, patient outcomes, specifically focus on at-risk communities. I was also part of certain community initiatives that would bring access to care to underserved and at-risk communities. So all in all, was always interested in access to care and innovative programs for vulnerable communities. And as such, I saw the glitches that existed, the barriers that existed on the patient side, on the doctor side, also understood the mindset of the payer, what was missing on their end in order to manage their patient's health better. And that's how the idea of bringing this venture to life came in. I
But
have
you
my,
didn't have necessarily a technology background.
as it always happens, my college friend, technologist, actually, we met at one of those social events,
Uh-huh.
didn't see each other for 15 years, exchanged the notes, and decided that we can collaborate on this.
Wow. And then how long did it take you from I mean, I'm sure it was a very long journey, but maybe in a nutshell, going from that meeting, that concept, that exchange of notes to the minimal viable product of it, right? To the first iteration of it.
3 to 4 years.
Okay.
It's a highly regulated area. We have FDA registration, we have patents. So it's conceptualizing the model. It's also creating technology for it, testing the technology. So about 3 to 4 years. And it was right in time, as you said, a couple of months before COVID, we actually
Right.
put it in use in the field. And little did we know how important it would become and how impactful it would become.
So, and that was going to be my next question. Tell me about your pandemic experience. That must have been a wild ride.
Sure. My husband and I are doctors, and we know how conservative healthcare community is in adopting innovation. So we understood that even though the technology could be great, we really needed our own Tesla showroom, as we call it, our own service arm that would bring this technology into the world. So the first practice was launched using this technology was launched in New York just 3 months before a pandemic started. And we became the safety net for most vulnerable New Yorkers. We worked with social service agencies. We worked with community organizations coming to the homes of people with multiple chronic illnesses, elderly, preventing them from coming to overcrowded emergency rooms. And
Do you work directly with the state on that?
No, unfortunately, not with the state, but we worked with community-based organizations and
Community-based
social
organizations.
service,
Okay.
and social service agencies.
Okay. Wow. So you got a trial by fire then, really.
Yes.
And
And
what's
then we sent our technology to Ukraine, and it's still helping the victims of the war with U.S. and other countries' physicians actually seeing patients in Ukraine. So unfortunately, we had the chance to test our technology in the
right?
most problematic instances.
And what surprised you in those early days? What worked really well that you didn't that you were surprised about, or and what were the challenges that you didn't see coming? I'm sure there were plenty.
Actually, I was pleasantly surprised on how effective this was and the capture and how we were able to, especially during COVID, to bring in one room a nurse from social service agency, a physician, patient relative who is locked in a different country, the patient who is locked in the home. It was quite amazing. The barriers, I would say, any other technology with experience, people doubting how it's going to work, uh, being an additional sort of burden of bringing a new program. So it was more of a bureaucratic
Okay.
obstacles.
And so we moved through the pandemic, and now, as I mentioned in the intro, it seems as though we had all this momentum behind telehealth, and it was going to be able to really expand access and maybe even potentially, if done right, add some efficiencies to it. Now, I know a lot of people started with telehealth; they weren't ready for it, and it gave them a bad taste in their mouth.
Exactly.
But it seemed like there was a lot of promise, and now it's starting to kind of wane. And I'd like your perspective. Is it there? You have three major stakeholders, right? The patients, the payers, and the providers. So where does that lie? Where is the challenge to adopting this? Because it seems like, especially as we talk about still with rural communities in particular, this is a wonderful technology that can probably be a game changer for many people.
Absolutely. I think the challenge with telehealth is technology adaptation by people who need it the most. Again, we talk about people who are older, people who come from under-resourced communities. So to me, this is one of the challenges with adaptation of telehealth. And then again, the diagnostic limitations of regular telehealth without any data. So I think this is where we shine. By the way, we support regular telehealth exams where necessary as well, not just a hybrid model with sending somebody into the home. We actually probably the only ones or one of a few that have three-way telehealth solution where somebody who is pretty much tech support originates the call and connects the patient with the doctor, making sure that patient overcomes all of the burdens of technology, which is very much appreciated by doctors community, because if you would ask a doctor during early days of adaptation of telehealth, majority of them would complain that they spent most of the visit for being a tech support for the patient.
Absolutely, sure.
Right.
I've experienced that myself, right? Especially during the pandemic.
So we help overcome this challenge as well with our model.
Okay.
Also, for the payer, again, keeping in mind, because we have to, as you said, there are three stakeholders, and we really have to make sure that we put the payer's hat on as well. So the reason that they were so hesitant in reimbursing house calls before COVID started, telehealth house calls, is because they could not understand how they would account for these visits. How do you know how long the visit was? How do you know that visit happened? So we actually help with accountability as well. Everything is time-stamped, geo-stamped, so you know what time visit started, you know what time any instrument was turned on, and then you have an artifact of that specific part of the exam. So there is a lot of accountability in these visits.
And I was just having a conversation with someone over the weekend about barriers to implementing not even just telehealth, but technology enabled healthcare. And that is because, in many respects, our payment model, and look, you have to get paid for it, right? It has to make economic sense if it's going to survive. Is the payment model is really structured around face to face visits, which of course makes sense because that's what healthcare has been since its inception. But we have so many tools now that can be used that don't require a face-to-face visit, right? But can really add a lot of value. And I think like this physical exam piece, of course, sometimes it's needed, but it can really act as a bridge. So how are you seeing payers respond to this? Are they embracing it? Are they resistant?
Actually, this model is great for the payer, as I said. And if you think about it, it's better than face to face in some instances because you bring data from these visits to the payer, which you can eventually analyze.
Sure. I mean, you think if this at scale, if you had the ability, you could probably reduce quite a bit of overhead. Definitely, it's a way that you could conceivably bring down the cost, I would imagine, a couple ways. Also, because if people are now making their visits, they're going to be more engaged with their healthcare. So, I mean, as you look out at the oh, go ahead, please.
I'm sorry for interrupting, but in a way, we are solving the patient. But by the way, ZIF stands for ZIP physician, where ZIP has to
Okay,
be.
thank you. I meant to ask that.
It means fast. We bring in physicians to patients in an expedited fashion. But the other meaning of ZIP is zip code. We're really focusing not just on bringing this high-end technology to patient's location, but also on patient engagement. And the way we envision it is through creating local partnerships with trusted sources, hence zip code.
Okay. And so that you talked about the inpatient visits, but also you do pop-up clinics. I imagine those could even be more fixed in certain locations, right? Because in a lot of communities, one of the barriers to getting people high quality healthcare is that they just can't get clinicians to be there, to move there, right? Especially again in rural communities. So is this a sort of thing where if you had a trusted resource, perhaps an office or a health system that's willing to partner with you, you could put in a facility, a small clinic in an outpatient setting, and some patients could just come there and the doctor could just see them wherever they are, right?
Yes, we've set up these clinics in schools and community centers and some of the health organizations, facilities, not necessarily physician offices, but healthcare facilities that bring
Hmm.
patients for other needs. We can do point of care testing. For example, we are very successful in running diabetes awareness campaigns where we bring point of care A1C hemoglobin testing. And those patients that have high numbers, we take them to the room with a closed door and they offer wellness visit right there and then. You don't have to
Wow.
rely for the patient to make an appointment, to book an appointment with a primary care physician, and then something is lost in translation. You address the problem right there and then. And it's actually a few problems that we are solving with our technology. One is access to care, but the other very important problem, which often is being overlooked, is health literacy. Sometimes patients just don't know that they have to see a doctor. They don't understand how often they need to see a doctor. They don't understand how that remote monitoring device that they're given, how to set up this device in the home. So we are solving for all of these problems because we are meeting patients where they are.
And so you're more or less the technology provider, correct? Are you a clinical operations team as well? Like, do you provide the doctors and staff, or are you more or less just the tech?
Sure. First and foremost, we're a technology company, so our technology is available for licensure to healthcare organizations. But because we work with payers, because we work with community-based organizations, some instances, these entities don't have their own physicians, don't have their own in the field people. So for that purposes, we have our exclusive service arms, which are medical practices that are affiliated with our technology. So it's sort of exclusive delivery arm.
And is that nationwide or is that only in certain states?
These practices actually operate today in New York, New Jersey, and Florida.
Okay, excellent. And so where do you see the growth potential, as you look forward in the next couple years? Where what are you thinking about in terms of growing the company and the technology and really expanding telemedicine?
So we actually think that the growth is in our partnership with large physician groups, those that manage so-called risk. I'm going to have terminology
Sure.
that's
Risk-based contracts, right?
yes, yeah,
Yeah,
risk-based contracts, value-based care. So
yeah.
partnering with payers, partnering with physician groups around the country, that's where we see the potential for growth. This technology is great for transitions of care visits when patient comes back from the hospital. And really, it's impossible for them to make it to their primary care doctor. And statistics says that in 70% of the cases, if they're not seen by the doctor within 2 weeks post hospitalization, they will be readmitted under 30 days.
Absolutely. Well, truth. I can attest to it.
This technology is good for comprehensive assessments to stratify patients by risk. And there is so much data that we gather through these visits. It's not just a subjective a patient survey. This is really based on recertification based on data. Primary care services for patients who are homebound. who do not leave their home. Again, this is a great model to support those patients. And of course, everybody talks about value-based care gaps that physician groups need in order to report to their respective payers, that payers need in order to respond to government organizations. So this is a great way for us to close gaps in care, such as annual wellness visit, well-child visit, point of care, A1C hemoglobin. We can close up to 40 gaps in care using this technology, all those that payers use for their star ratings.
And you can work with all different electronic health records?
Absolutely. Thank you so much for this question, because if you just run a mobile practice, you can use our platform as a practice manager, as an EMR as well. But if you're a large system and you do have your house call arm, but otherwise you also have brick and mortar facilities and you have your Epic, Cerner, eClinical, or any other software, we can easily integrate. We've done this before with already some of this practice management platforms, but absolutely we can integrate with other systems.
Okay. And are you
And the way
thinking
we
about
integrate is
inpatient
not
care
just
at all?
and the way we integrate is not just a simple flow of the doctor's note between the systems. We actually have full deep integration, including schedules, including data, like pictures, sounds that goes
Okay.
between the
So
systems.
yeah, so you actually transfer the files into the
Yes,
you have right access into the
yes.
electronic health records. Okay. Are you thinking about inpatient care at all? What about for the remote hospitals who are struggling with a similar problem? Is that
Absolutely. Absolutely. This technology could be used for a hospital, for example, it has multiple satellite locations.
Mhm.
And it's impossible for them to staff every location with certain expertise. So stationing this technology on different campuses will enable these experts to oversee multiple locations, multiple campuses.
Wow, this is fantastic. I mean, I'm sure it has existed much longer, but I haven't seen this. If I'm ever in New York, I hope maybe I can come by. I'm in Philadelphia, so maybe I would love to see it in action because it sounds like it could really be a game changer. I guess I would kind of close with a two-part question. Number one is that if there are organizations out there who are struggling to deal with their telemedicine, they want to implement telemedicine, but they're struggling with it, just some initial tips about how can they kind of make that a better program since you're living in it every day. And then secondly, and of course, importantly, how can they get in touch with you?
Thanks so much. I think when you implement these programs, when you try to implement these programs, just like anything, any other programs, you have to always think about all the constituents. You have to think about the capabilities of the patients, because whether you like it or not, the patient is the end user. So it could be the greatest technology, but if it's hard for the patient to adopt it, it will never work. So you have to study the capabilities of the patients. You have to also make it attractive to doctors so
Mhm.
that it doesn't present an additional burden, so that it actually helps them in managing their patients. So I think thorough discovery process and exploring the capabilities and the needs and the challenges on each of this stakeholder is something that helps you implement telemedicine and any other program.
Right, bring in all the and the payers too, right? You at least, as
And
you
the payers
said,
too.
you have to bring all those stakeholders together, and everyone has to be committed to it.
And
So,
for the
how can they
payer,
find out?
it's going to be access, connecting them to their most complex, highest cost patients, and cost reduction.
All right, tell us where we can learn more about ZiphyCare.
ZiphyCare.com, ZiphyCare.com. Welcome.
Wonderful. Well, this has been enlightening. Again, I hope to see this in person someday because I think it's fabulous. I think this is the way of the future, like many of the things that we're doing right now. So I'm grateful for you spending some time with us, telling it about it. And I will be following you to see your future successes.
Thank you so much. Thanks for inviting me. One day I want to talk to you as a cardiologist also.
Absolutely. I'm game. All right, everybody. Thank you so much. I hope you enjoyed this conversation. Look for ZiphyCare in a pop-up clinic near you someday, we hope. And until then, be well. We'll see you next time.
Thanks so much. Have a great day.